We move on to the next talk, and that is by Dr. SP Tiwary, Dr. Tiwary, and he will be telling us some tips to manage macular HST with RD.
Good morning, all of you. Thank you, sir, for inviting me here for my talk. Slides, please.
I just request the speakers to stick to 2.5 minutes time. Yeah.
So, as we all know that in the era of micro-incision vitrectomy system, the management of retinal detachment has become more and more simplified. We work on three basic things while doing retinal detachment surgery. We have to remove the vitreous completely, and if there are membranes over the retina or behind the retina, we have to remove the membrane as well as vitreous. We have to close all the breaks by doing laser barrage or cryopexy, whatever is suitable, and we have to give a tamponade. But a typical challenge comes out whenever we face a break near the macula, or if the break involves macula. If we go on do laser barrage or cryo or whatever, that will destroy the functional macula, and the outcome will be suboptimal and not that good. So what modification can we do? This is just a chronic retinal detachment. Temporal area of retina was detached, and there was a large macular horseshoe tear with everted edges. It was a chronic RD of over 2 years duration. So we started the surgery with just removing core of the vitreous, staining with tricot, and then we tried to peel the internal limiting membrane by staining the ILM, because the edges of hole were everted. So just to relieve the traction. And then we decided to do a retinal autograft by taking a part of the retina from the superonasal area of the attached retina. We did all around 2-3 rows of endodiathermy to cut the piece of a retina from the adjoining area. And after doing that, we just put a PFCL, and we tried to negotiate that free flap of the retina in the macular area. The technique was little bit challenging, as I was trying to do a unimanual. If we switch on to bimanual surgery, I think this grafts negotiation would become much easier by using chandelier light or something. So just freeing the flap of that retina from the adjoining retina, and then that retina flap was just hold on with a aspiration. Cutting was switched off, and aspiration of the cutter was used to bring that flap over the macula. And then just put the flap over the macula and just tuck the edges around that whole large hole lying over the macular area. At present, the eye is under fluid air exchange, and we can see that the free flap is reasonably well sitting over the macula, and hole is absolutely closed. We didn't do any laser around that hole, and just the graft area was closed with laser, and 360 laser barrage was done, and silicone oil was injected after completely drying that macular HST. That led to perfect closure. Silicone oil was removed, and later on patient developed cataract. Cataract surgery was also done, and for last 1.5 years the retina is absolutely attached with good outcome. So thank you so much. I just wanted to show this technique to manage posterior breaks of retina.
Thank you, Dr. SP. It's a wonderful presentation, because our main concern was how to handle a posterior break with a retinal detachment when the PFCL can actually go behind, and he showed beautifully how to do that.